Thank you very much for the invitation to this event. I'm very excited about. You just heard, I started in philosophy. I did my work on Hegel, but then I was migrating out of philosophy and I went more into the field of bioethics and applied ethics. And when Tanya asked me whether I would like to come over and give a talk in this workshop on beginning and end of life, I first was thinking of, or I was asking her, what would you like to have? What kind of talk would you like to have? Because my recent work or my recent positions, I did a lot of policy making work. I was working for the Swiss National Advisory Committee on Biomedical Ethics. And this is something might be comparable to the Nuffield Council, but it's not a research institution like the Nuffield Council, but it gives a lot of ethical recommendation relating to decision making in medicine and healthcare provisions. And so we were a lot of thinking about what would be actually also good laws to do to regulate medicine and healthcare, and what would be good reasons in order to regulate these fields. I was also working for the Swiss Association of Medical Sciences. This is the Swiss Academy of Medical Sciences. What they do is really do soft law for physicians in Switzerland. So there I was working on advanced directives. I don't know, I think it's called living will here in Great Britain. You know what this is? It's kind of this is, you can write a document as a patient when you're in the power of decision making, in order to give out provisions or in order to give out orders for future situations you might be in, but you are not able to make the decision on your own anymore. So, for example, you can ask to terminate a certain kind of treatment in this or that stage when you lose your capacity of making decisions. So this is like, the idea is like that you could prolong your power of making decision into a realm where you're not capable of making the decision anymore. So this is a lot of, I'm sure it's also here in Great Britain, there was a lot of debate about, is that possible to anticipate future situations? Is it possible to vision yourself dying and what you then want to do and how you want to be treated? And this is more at the end of a life kind of decision making. Another project I worked on is on medically assisted suicide, which is allowed in Switzerland. So there also you have to ask yourself how much freedom or can you allow another person to give you a medicine for the purpose of commit suicide? Can you allow a physician to do that? Or does it contradict the ethos of medicine as such? But today I want to bring forward another topic I'm working on, namely reproductive medicine and genetic diagnosis in that field. So I said, well, I would like to start with the beginning of life, and the title of my talk is In Control, Making the Unborn Genetically Transparent. When I started to think about this topic, I was thinking, I just read your description you wrote, and I thought, well, you really want to think about the beginning and end of life from a very specific angle. Namely, you want what an individual is experiencing and what an individual is feeling when giving birth or when being born and when dying. So as I understood it from the description, the purpose of today's workshop is actually to reflect upon two fundamental experiences in which all human beings, actually all mammals, are equal. Entering into life through the body of a woman and exiting life at some point. So the finity of human beings is also something that is common to all of us. And so you're not wanting, today you don't want to reflect on that birth and death from a medical point of view or a legal point of view, what to allow or not to allow, but rather from a subjective point of view, namely from the perspective of the experiencing subject. Also, as I understood, your angle is that you want to emphasize two aspects of this experiences of coming to life and dying, namely that this transitions are an experiencing of being out of control. So control is something that is a main topic today, and this being out of control might cause a certain feeling, namely fear. So the assumption that you make here, the workshop conveners, is that being out of control makes us fear, causes a certain feeling. Then you have some kind of an epistemic claim, namely, you think if you understand this fear, where it is coming from and what it is directed to, we understand something about these fundamental human experiences, namely birth and death. And also in your description you have a little bit of like a kind of a normative claim, namely that we should cope with this fear. And one way of coping with it is a way of understanding where it's coming from, the origin of the fear, and to which it is directed. This coping is important or is plausible from a psychological point of view. So psychologists or psychiatrists tell you you need like some kind of a middle level of fear in order to be agitated enough, interested enough in order to act. You need to focus and pay attention to the task in front of you. But you should not should not have too much fear so that you would be hamstrung, that you're not able to act anymore. So fear and control and coping with fear is also very important in order to be an agent and to stay, to have the possibility to act. I would like to just kind of laid out how I understood your angle or your approach to the topic of beginning and end of life and the reflection you want to undertake this afternoon. And I would like to make 3 points now in my talk. First, I would like to remember you, I'm sure you're familiar with the conceptual distinction between fear and anxiety. Then my second point is that the fear of something might be the expression of a deeper going anxiety we encounter in birth and death. And here I will focus on birth, on the beginning of life. And my third point will be that the anxiety in pregnancy could be also understood as an expression of freedom and responsibility, something that will be explained later by thinking about the conceptual distinction between fear and anxiety. So I come to my first point, the distinction between fear and anxiety, and of course I draw into on the tradition of existentialism, on Heidegger, Sartre and Kierkegaard, and I'm very happy that I have an expert here. I'm not an expert in this, but I just found it very interesting to look back to this distinction, or what can we learn from that for the questions you laid out for this workshop. So for Heidegger, fear always has an object. It is concrete, it is directed towards something that you fear. Anxiety, in contrast, is something that doesn't have a particular object. It's such a being in the world, is that correct? Dasein in der Welt. It's an existential experience that you feel anxiety, but you cannot put your finger on what it is actually that you fear. So what this means, like this kind of being overwhelmed by the fact that the world is there, Sartre kind of coined the term of contingency of the being, which is there's no particular reason why things are the way they are. There's no real fixing point you could start from and then see everything unfold what is in the world, but it's rather you just rather have to realize that how the world is in some sense contingent. There are no ultimate reasons. And I thought it might be, if you think about a very clear night and you look up in the sky and you see the skylight, you can easily get dizzy. So you can have that kind of experience of vertigo because you don't have a fixing point. You don't know how to start. It gets better if you see then the star pictures and recognize, oh, there's a big wagon or something like that when you start systemizing it and putting things into order. But first, you might have also this kind of feeling of non-orientation anymore. Kierkegaard, to go a little bit back, kind of tried to make a conceptual connection between this feeling or experiencing of anxiety with freedom. What he meant with that is that, or what is meant by Sartre and Kierkegaard with this existential form of freedom is, it is a fact that I'm in the world, I cannot do anything without it, and it's a fact that there is no ultimate reasons why things are the way they are, but I also have to recognize that there are no values or no ultimate norms that I can orient myself to in my life, but I realize I can become aware that I can make decisions, that I can lead my life, that I can be an agent, that I can be an actor in my own life. So this might cause a feeling of vertigo on the one hand, but it also might give you an awareness of freedom, which is not just a trait of adults or so, or of individual, but rather freedom as a description of the form of life we are living. And one way of kind of moving more into this direction of freedom is then to take on responsibilities for things and circumstances that are given, which might also have might cause a feeling of guilt that you, in some strange sense, although you know that you're not responsible for, or that you didn't cause things, you might still feel kind of a guilt, a pangs of guilt for the things, how the way they are. So, like I said, freedom as a form of more of an existence, not of traits or features of individuals. This was a very brief try to remember this connection between anxiety, freedom, and responsibility. And I will explore that further when we will get more to the genetic diagnosis around pregnancy. I want now remind you of my second point is that to fear something in particular might be in reaction to this overwhelming experiences of anxiety. So it might be actually a coping strategy of turning anxiety into fear by giving your feeling of fear an object. And I would like to make the claim that fear might be understandable in that sense, understood in that sense that you're given a particular object you can direct your feelings to, that this fear might be understandable but not a totally adequate reaction to anxiety if it just results in the overwhelming urge of being in control of things. And by that, ignoring the aspects of freedom and the responsibility that comes along with anxiety. That is the awareness that there's no ultimate reasons for why things are the way they are, but nevertheless, you can take them on and incorporate these things in your course of action or in your course of life. And to explain this or make this, give an example of this kind of claim I would like to make, I will now turn to genetic diagnosis in prenatal care. Genetic diagnosis, you have two, or you can distinguish two areas where genetic diagnosis, diagnostic methods are used in reproductive medicine or prenatal care. One is pre-implementation diagnosis. This concerns reproductive medicine, where you have medically assisted ways of, or in vitro fertilization, where you have an embryo outside the woman's womb, and you can do genetic diagnosis on that embryo in vitro and decide whether you want to implement that embryo into the woman's womb or not. So there you have a question, or the main question is then what kind of genetic information are you allowed to get from that embryo, and how should decisions of implementation be made or not. As far as I know, it is allowed in Great Britain, right? PID. Yes, it is. Okay, we have now, in Switzerland, we will decide on this. The people will decide whether this option should be given in Switzerland or not. Mid of June, we will have a Volksabstimmung, a big vote on this. Then the other, I'm not so much interested now in this afternoon in the pre-implementation diagnosis, because what is at stake there is the decision about implementing an embryo or not. I'm more interested today in the prenatal care or prenatal diagnosis, genetic diagnosis. That means that you diagnose an embryo or fetus which is already in the woman's womb. Because what I find interesting here is then you have a totally different questions. Namely, you have to decide whether to continue or terminate the pregnancy. And this is, of course, a different ethical question there. Because it's about abortion and it's about the intrusion into a woman's body. So for the fetal genetic testing, prenatal testing, you have invasive methods of testing. Amniocentesis is one, where you're testing the forewater. It's where you can do it at the 15th week of gestation. Before that, also as an invasive testing method is chorionic villus biopsy. I hope I pronounce it correctly. That is, you test the hysteroid of the placenta of the woman. You can do that already beginning from the 9th week of gestation. So what you do is actually you stick a needle into a woman's body, in a woman's belly, in order to get these samples of forewater or of the placenta. So you see already it's kind of invasive in that sense that you really go through the body. And also there is a small risk of a spontaneous abortion when you're doing that kind of procedure. So physicians were very happy, not only physicians, but also women were very happy when a new form of tests were coming on the market in 2011. They started in the US, and now it's also, I'm sure it's also in the I'm sure it is in the UK, because the UK has a whole, what they call an NHS rapid project. So you have a website on that new kind of testing, which is a non-invasive prenatal testing. What you do there is you just take a blood sample of the pregnant woman. You can isolate from that blood sample, you can isolate the fetal DNA. The fetal DNA is they call it cell-free. I'm not a physician, but it is, for some reason, it is possible to isolate the fetal DNA, although not, it's still mixed, of course, with the genetic information of the mother. So this testing has a very high accuracy of 99%, but it's still called a testing and not a diagnosis, because you still have to deal with probabilities. So it's not, it is not possible to make your sample so pure, sorry for the colloquial, but so pure that you could really say, I can do a diagnosis of that kind of blood. So you see, it's non-invasive in the sense, of course, it's also invasive because you need a venal blood sample, but of course it has no risk of abortion, and it's very easily can very easily be made. And it's more accurate than the so-called triple test, where you have a combination of a blood test, an ultrasound you make of the fetal, of the embryo, and the age of the woman. There you can do a calculation. This is called the triple test. So it can be a substitute of the triple test for knowing what kind of genetic design the fetus has. So the 99% accuracy is actually only for the test of trisomy 21, so the Down syndrome, I'm sure you're all familiar with, and this is also the main reason why this test is being made. But the test has great potential, so there's the hope that you can also find single gene disorders with this test. or that you can find an autosomal recessive condition such as cystic fibrosis with this test. There's one test which can be called a diagnosis, so it has a sure result. It's you can test or diagnose the fetal rhesus D typing in rhesus D negative mothers, which is very important because then you can give medication in order not to have the embryo, the fetus, in danger because of this blood type. And people are working on to have the whole fetal genome sequencing also through this blood test. So what you have here is the situation that you very easily, just by having a blood sample, you can have the idea is that you can make the whole embryo genetically transparent to outsiders. So if you think about the motivation of undergoing these kind of tests, genetic tests during pregnancy for women, and having in the back our topic, today's topic, you could interpret this kind of motivation, or you can interpret this kind of interest in these tests for the women to get a grip of the unknown, because you don't know who the baby is, will be, and you don't know how your life will look like with this child. So one way of reacting to this unknown is you try to get a lot of information about the unborn child. Of course, this is kind of a deception to some degree, because the information cannot give you a real answer to what kind of person you will give birth to, and it cannot answer how your life will look like with this new person. But I think you can interpret these kind of testing, or this high motivation of doing these tests, it may be channeling the fear, channeling the anxiety that you have in general, encountering something happens, it's independent of you, and you somehow have to deal with it. You don't have influence on it anymore. You can channel that by focusing on a specific object, and the object here would be the health of the fetus. So you can channeling the anxiety of not knowing about the world as a fact, evading from reason, into a fear about the health of the unborn child. I think there are certain shortcomings of this way of dealing with uncertainty or anxiety, or that it really that anxiety really just becomes a fear, and actually a fear that you can cope with and can actually eradicate. And the shortcomings might be the following. Women who decide to undergo these kind of prenatal testings are sometimes, there are surveys that show that they're not really, they don't really know what they get themselves into, or what the significance of the genetic tests are. First of all, a lot of women think that you can test your child whether it's healthy or not, but that's not true. You test the child whether you test the fetus whether it has trisomy 21 or not. That's something totally different, because just only a minority of disabilities actually is genetically caused. Giving birth is much more, you have a much higher risk of then maybe having a disabled child than in comparison to the genetic causes. So doing the test is not getting a ticket for a healthy child. So this is one very important misunderstanding, and which actually would need counseling from the physician who offer these kind of tests. Also, genetic features are something that you cannot change and cannot cure. So with the exception of the rhesus, fetal rhesus D typing, with the exception of that, because you can do something during pregnancy, you often encounter you cannot heal trisomy 21, for example. So this is also something that you have to keep in mind when undergoing these kind of tests. Also, with testing in general, not just genetic testing, but testing in general, you have to deal with probabilities. So that means there are false negative and false positive ones. So you could think, well, 99%, that's almost certain then. But if you think that every woman undergoes these, every pregnant woman would undergo these tests, these are a lot of women, so this 1% gets also, that's fairly a high number than in an absolute number or in total of wrong or false results. Also, if you have a result, for example, that you have a high probability of having a fetus that has trisomy 21, you don't know the degree of disability. This is a very big point or very important criticism of organizations that are promoting the situation of disabled individual with disability. You don't know the degree of disability, and there's a very wide range. So you have Down syndrome children who can actually go to university, but you can also have disabilities, trisomy 21, where they don't live very long. They have to undergo a lot of operations because there are heart problems related to their disability and other problems, other very severe health problems. So you have a very, like with normal or with health, so-called healthy children, you have a very wide range of expression of this genetic disposition. Also, it is when you make the unborn child genetically transparent, you could think of, you give birth and then you could give a CD to the child with the genetic sequencing. You could say this is a kind of infringement of the children's right to an open future. That is the right not to know my positions. So this knowledge, you can't take back that knowledge that you generate of the unborn child. And it's very interesting that it is in Switzerland the case, but I think also, I'm pretty sure also here in the UK, it's much easier to get genetic diagnosis of fetus, embryos and fetus, than for a born child. So there, because of this right to an open future and the right not to know. So you have an unbalance here as well. And what also, like these surveys on interviews with women show, is that they want to do the test because they think, oh, I'm supposed to do this, but they don't really think it all the way through, namely that the real decision is, do they want to terminate their pregnancy or not when getting the results? So that might result into a conflict that on the one hand, the role might be, I want to be a good mother and I want to be a responsible mother, and the aim of taking up prenatal care is actually ensuring the well-being of future children. But this caring might lead to the paradoxical situation that they think it might be their responsibility to terminate the pregnancy, that would be the best interest of not being born, because the being born might mean a lot of suffering from their point of view. Or also they might consider their own resources or what is bearable for them and also for other family members. Can they raise a severely disabled child within the family setting they are living in? So I come now to my conclusion, when thinking about bringing the first part of more like the conceptual division between fear and anxiety and how it might be related to freedom and responsibility, and the second part, this example of non-invasive prenatal testing, genetic testing, you could say that genetic testing is an attempt to get a grip on a situation that is characterized by great uncertainty and might be a response to that anxiety by fearing about the health of the child. One could say genetic testing fails the expectation of the woman to have real reassurance to give birth to a healthy child. So this might be could be seen as a downside. They cannot control the uncontrollable. They cannot control what kind of child they will get and how their life will look like. But one also could look at the whole complex from a different angle, and that would mean that prenatal care and genetic testing as being part of it is a way of taking responsibility of things the way they are without ultimate reason, to endure the contingency and anxiety that comes along with it and to convert it into an expression of freedom and making a decision about the testing and also about the action that might follow from it. So it's not so much to control the unknown that is the aim of prenatal testing, but you could understand these decisions about such testing as an expression of caring for the unborn, of taking responsibility as a mother, and of experiencing one's freedom in making decisions in the light of the well-being of another future human being. Please don't understand me wrong. I don't want to promote testing, but I just want to say that the situation to make these kind of decisions about testing, about what to do with the results, and also making the decision not to make these tests, can put you into a position where you can experience some kind of freedom as being an agent, being able to make a decision about an area which is kind of about a field which which is contingent and which might fill you up with fear. Thank you.
Well, I mean, one of my difficulties in thinking through these issues, and this was also indeed a difficulty that I actually had, was to just try and see what could be the best point for making the decision. I mean, it's exactly this dilemma that you were talking about, that if you get the news that there is a likelihood for disability, would you then, or more precisely for Down syndrome, would you then terminate the pregnancy? And it seems that there are sort of a number of moments where one sort of just isn't sure whether one could take the decision or not. In other words, sort of just beforehand, before even doing the test, one might ask oneself, so can I live with this situation? Can I imagine myself living with the situation of having a child that will have Down syndrome? And one might find it extremely difficult to decide that. And then the question is sort of, would it in any way be easier after having found out through the test? And you know, in some sense, I guess that would not really be the case, except that sometimes in life, I think when one knows a fact, one suddenly also knows a little bit better how one actually feels about that fact, if it has actually become an actuality rather than just something completely theoretical. So I guess I'm asking, would you have any advice, perhaps, in sort of how people could go about making this kind of decision? Or is there a sense in you as to what would be the best point at which one can ask oneself that question as to whether one would be able to live with a Down syndrome child?
Well, I don't have an advice because I think it's very individual. Like the situation is always very, it's never the same, so you can't just give a general advice on what to do. But my point is that you have to think about this, that you might be confronted with this question when doing the test. So I can understand your point that sometimes things becomes clear when you are actually in the situation, and they are unclear if you're just imagining the situation. But you have to make a decision whether you want to be put in that situation in the first place. So and I think this is what interviews show, that women are not sometimes even unclear that they have to, that they might encounter the second step. And so, of course, you could say, well, I want to be confronted with that situation, or I want to, but then you go in there with open eyes, and you don't need to know the result before you do the testing. You don't need to know your own, you don't need to know what you would decide, but you need to know that you are put then in a situation, be put in a situation where you have to decide.
One comment is that you, when you talk about the testing and everything, you always assume that the person tested is a woman. Just wanted to point out that there are men with wombs, talking about transgender men, and maybe you can think about how you phrase things in order to avoid like sexist language. And the question, I think your assumptions can be read as a bit ableist, in the sense that like disability is always a bad thing. But when you look at how society is structured, often the disabilities, the reason there are people with disabilities have a hard time is because of how society treats them. And I agree that parents can have a very difficult time, and that's something that needs to be considered, but it's also about how you maybe think about the role of the state. And again, like now all the responsibilities on the parent, but providing a more kind of caring state, you could take care of that and, get the state to help with a lot of the difficulties and provide a lot of the help. So yeah.
Yeah, I think this is a very important point, that disability are often seen in that framework as something to be avoided, right? We have a project now on this NIPT, where we have a lawyer, a law professor, 2 ethicists, a sociologist, and as an economist, thinking about the NIPT. And the economist, she said to me, look, when I read this cost-benefit analysis of NIPT, I just ask myself, what is the benefit? So how can I phrase the benefit in a way that is not discriminating? And it's like, it's kind of, I have a bad feeling of thinking the benefit is to avoid disability as something to be bad. And so, yeah, I think this is a very important issue when thinking about, it seems to be so clear-cut, healthy is good and disabled is bad, but there might be also something, an answer from the individual perspective, that there is a different order of values also. Yeah. And then with the state, of course, they should, when states, when states move forward, like in the discussion in Switzerland, where they now want to do the step with the pre-implementation diagnosis, it's always then also said, and we also want to give, we want to encourage, we want to give support to people with disabilities. But another way of a very important function of the state and laws is also what kind of traits are allowed to be tested. So their gender was, the sex was one, sex determination is one very debated issue. So they decided we don't want to have sex determination before the 12th week of gestation, because then you can have an abortion without giving any reasons. So we don't want to have a sex-based decision on abortion. So sex can only be determined in order to, when you know about a very severe illness that is passed on always on the male side or the female side. This is the only reason allowed. But especially when you think about the whole sequencing the whole fetal genome, you're very much then moving into the area of, well, first, genetic is far from giving you clear information about what to expect. Sometimes you see genetics, you sometimes see anomalies, you see something is different, but you don't know what that means. Then you communicate, something is different, make these people unsure, but you can't interpret your data. Often you can't interpret your data and to know and tell people what it actually means than to have that kind of mutation or something which doesn't look right. And so this is a very important, like in medical ethics, it's a very important discussion about what what tests should be allowed, where should we also draw the line of what should be tested.
And one last question from Gordon.
I was just wondering if there is any empirical data to show whether or not the decision to test makes more likely the decision to terminate down the line if the test turns out to be positive for the indicator.
Well, I just know some data from, or the data that is known in Switzerland. It's and it might also include other countries as well. So you have actually the rate of birth of children with Down syndrome, it increased over the last year. That really depends on because the mothers are becoming older. So there is speculation about why do we have actually more children with Down syndromes. So is it since you have already diagnostic measures, this triple test I was mentioning, it also has an accuracy of I think 90% or between 80 and 90%, so it has a very high accuracy. So there seem to be a lot of women who know that have a higher risk of giving birth or a higher probability of giving birth to a child with Down syndrome, and they might refuse these tests or might have a test and not take then the step of terminating the pregnancy. So it's not like the horror scenario. Oh, when we test, of course, all these children will be, or all these fetuses will be aborted. This scenario is not true. But there are also other evidences where it is, or other surveys who say, well, actually, a woman who gets that test result, she is more inclined than to do an abortion than not. So the data is kind of contradictory. You have to, but you also have to know that that the percentage of having an abortion because of a disability is much lower to the percentage of the overall, or in relation to the overall abortion you have per year. So other reasons are much more, way much more in this rate.
Good. So then thanks Susanne once again for her talk and discussion.